next lecture is by Dr. Prashanth Prabhu. Dr. Prashanth Prabhu is working as an assistant professor in audiology at the All India Institute of Speech and Hearing, Mysore. He has completed his bachelor's, master's and PhD in audiology from All India Institute of Speech and Hearing, Mysore. His research areas focused on assessment and rehabilitation of auditory neuropathy spectrum disorders, tinnitus and hyperacusis. He has published several articles in reputed peer-reviewed national and international journals. He has also authored 5 book chapters and served as a reviewer for several reputed international journals. He has also served as resource persons at several workshops, seminars, and conferences. With this introduction, I invite Dr. Prashanth Prabhu to deliver the lecture.
Thank you, Dr. Sriraj, for the introduction. Okay, so the last lecture for today on audiological assessment of hyperacusis. We have had 3 wonderful lectures till now. So the openers and the middle order batsmen have given a wonderful start for the webinar. Okay, so and now at the end of the day, so it's I have to finish off well. Okay, and I have little lessovers also in terms of the time, so I would try to finish it within time, and I'll try to give my best for all of you. Okay, so the topic that I'll be talking about is audiological assessment of hyperacusis. So when we hear the term hyperacusis, most of you would have studied about it. I mean, when you were in college days and all that, and we see a bit of less cases specifically to hyperacusis. Sometimes we consider it as a rarity, but we do get many patients with hyperacusis, and at that time, as a clinician or as a student, we are not very sure what exactly needs to be done. How to go about it, what all problems do they face, how as an audiologist we should approach and tackle a patient in terms of assessment if he has hyperacusis. So this lecture we will try to learn what all techniques are presently available, what all tools are available for an appropriate assessment of individual with hyperacusis. So my agenda for today's talk we'll be talking in brief about the different terminologies that are related or similar to hyperacusis, how we differentiate them, the definitions, and we'll talk a bit briefly about the prevalence of hyperacusis, how prevalent it is, and the major part, that is what are the different audiological assessment tools. And I'll talk briefly about one case study of that was tested at All India Institute of Speech and Hearing, Mysore, and we'll briefly discuss about some of the research ideas on hyperacusis and the talk for the day. Okay, so the definition of hyperacusis. Hyperacusis is defined as an unusual tolerance to ordinary environmental sound that is considered to be normal or for a normal person, which is tolerable, something like maybe a phone ringing or somebody a bell ringing or somebody even talking at a comfortable level. So all those are normal. But for an individual with hyperacusis, if they are finding it difficult to tolerate such sounds which are around 60 to 70 dB also, that are usually tolerable for a normal person, if that is the case, then we define or then we classify them as having hyperacusis. So sounds may be perceived as uncomfortably loud. So what can happen when these sudden sounds or these sounds, slightly loud sounds, go to an individual with hyperacusis? It's like they can be uncomfortably loud, unpleasant, frightening or painful. Okay, so Richard Tyler and colleagues, they have proposed 4 types of hyperacusis. Okay, they call it as annoyance hyperacusis, a sound which can really annoy you, and fear hyperacusis, it can induce some sort of fear, and loudness hyperacusis, that is it is too loud for it is intolerable for the person, and pain hyperacusis, it causes pain. So the sound can have all these 4 different kind of experiences. So one way of classifying it based on the experience of the client is all these 4 that was given by Richard Tyler, but there are several different terminologies for this. Okay, and one of the common terminology that is used, or that's an important terminology that we have to understand, is called as misophonia. It is a strong dislike for certain sounds which is unique to an individual that can result in a negative emotion or a reaction. So Dr. Sriraj also talked about it in brief. So somebody chewing in a dining table, or somebody constantly clicking the pen, somebody making a sound while swallowing, somebody whistling, or somebody scratching the table, etc. All these are sounds that are like which induces a strong dislike kind of an emotion, and that is referred to as misophonia. All of us get this misophonia symptom, but only for like very specific sounds. It is not a major hindrance for us, but there are few individuals, even for very, they get annoyed with the sound. they are like aversive and they dislike majority of the sounds, and then we diagnose them as misophonia. Initially, people used to call selective sound sensitivity syndrome as well, but now the common preferred term that has replaced it is misophonia. So we use the term misophonia, and this was actually explained and coined by the Jastreboff, that is Pavel and Margaret Jastreboff, and we have a lecture tomorrow on misophonia by Margaret Jastreboff, where we'll be learning in detail about the assessment of misophonia. But why I'm telling you this is again something which can overlap with hyperacusis. So as a clinician or as an audiologist, we should be able to differentially diagnose and say this is probably hyperacusis and not misophonia. So we'll try to learn how we can differentiate that. And another term that we also used is phonophobia. Phobia is fear, phono is sound, so fear of sound. So there's a constant, persistent, abnormal fear of sound, and that is referred to as phonophobia. That is majorly classified under as a psychiatric condition. A psychologist or a psychiatric intervention is needed to overcome phonophobia. So the common term, nowadays we use a term called as DST. DST refers to as decreased sound. So all these disorders which I explained are classified under an umbrella term, and that is used as decreased sound tolerance. Okay, so decreased sound tolerance is a common term used including hyperacusis, misophonia, phonophobia. So Jastreboff and Jastreboff suggest that anyone who comes with a complaint of tolerance issues, they can be broadly classified as decreased sound tolerance. Then we should specifically identify if they have misophonia, hyperacusis, or phonophobia with appropriate tests and plan management accordingly. So this is a terminology that recently is being used even in research literature and also in the clinical literature. So what's the major difference between hyperacusis and phonophobia and misophonia is it has an emotional response to specific sound. Okay, so when a sound is present, if somebody gives a negative or an emotional response to it, then that is more seen in phonophobia and misophonia. Hyperacusis is more of a loudness annoyance, basically loudness hyperacusis, where loud sound you find it difficult to tolerate. Okay, so this is a recent study by Pellicori in 2020. So where they try to separate, what are the factors that can differentiate misophonia and hyperacusis. Okay, and common thing is all of them have decreased sound tolerance and both of them have normal hearing. Okay, and they may have some amount of emotional issues, but misophonia is they get triggered by both auditory or some visual stimuli as well, but hyperacusis is mainly an auditory stimuli, and it is dependent on the physical parameter, and it's like physical parameters are irrelevant in misophonia. What do I mean by that is, and hyperacusis, it's dependent, which means a loud sound which is intolerable to the person. For example, if there is a bell ringing that is intolerable, if that is presented at 20 dB, 30 dB, there is no hyperacusis. But if the same sound is presented at 60, 70, that causes hyperacusis. But misophonia is not like that. A clicking sound at 10 dB is equally, annoying for a person, even if it is presented at 40 dB. So that doesn't change. The physical parameter is irrelevant in misophonia and it is highly dependent in hyperacusis. That is one parameter that can differentiate. As an audiologist, the important parameter that can help us differentiate is the dynamic range. So misophonia individuals do not have usually a decreased UCL, so their dynamic range will be normal. But if I have reduced dynamic range, then mostly the person will have hyperacusis. This is one indicator clinically that can help us differentiate maybe it is misophonia and hyperacusis. But along with this, a psychological assessment is always required to confirm that maybe it is more towards annoyance and not towards just a loudness based disorder. So this is just an overview about how we can classify misophonia and hyperacusis. In tomorrow's lecture, we'll deal in much more detail about how misophonia is affecting us. Okay, and we did a study recently on how how many college students. We did it on 500 college students, and we tried to find out how many of them have misophonia. So we found like almost around 14% of them do experience misophonia. And the recent audiology literature talks about the role of audiologists also in misophonic assessment and management. Okay, especially CBT in misophonia, and also we have found there are research evidences which show abnormal contractile suppression of OE in misophonia, and there is audiological intervention also needed in individuals with misophonia. There is a lot of studies that can be done, especially in individuals with misophonia, and our recent Indian study shows that there is a lot of prevalence. So there is a need to explore more with respect to misophonia. Okay, so coming back to hyperacusis, another common question that is asked by my students as well, and all of you would have a confusion, is how is hyperacusis different from recruitment? So all of us have learned about recruitment. Recruitment is an abnormal growth of loudness. So how is recruitment different from hyperacusis? Okay, so there are few indicators that can help us differentiate hyperacusis and recruitment. So for hyperacusis, all sounds are mostly moderate and even loud sounds. Even moderate level sounds are uncomfortable. But for recruitment, only loud sounds are uncomfortable. Only when the sound exceeds 80, 90, only then it becomes uncomfortable. But even at 50, 60, etc., if you are getting uncomfortable sensation, that mostly that is hyperacusis. Another major indicator is hearing loss. Okay, and individuals with hyperacusis will have no or minimal hearing loss. They will have very less hearing loss, but hearing loss is very prominent in recruitment, because one of the reasons for recruitment is possible outer hair cell loss and a possible cochlear hearing loss. In those individuals, we experience recruitment or hyper-recruitment that is more common. Okay, so if hearing loss is present, then we should be careful in diagnosing hyperacusis, because maybe they may have recruitment. Okay. And hyperacusis varies with mood. So there is a slight emotional touch also with the hyperacusis. So the emotional, structure of the patient, how his emotions are working, that can affect hyperacusis. With different emotions, the hyperacusis degree and everything can vary. But recruitment is not like that. It doesn't vary with mood. It's only intensity of the sound specific. So that's how clinically we may have to differentiate whether it is hyperacusis or recruitment. Another thing what you have observed is, especially in children with ASD, autism spectrum disorder, a common symptom that we see is they do not like loud sounds. So they cover their ears whenever they hear loud sounds. So hyperacusis is also, or decreased sound tolerance is common in individuals with autism spectrum disorder, Williams syndrome, and even in individuals with APD, auditory processing disorder. So, there is an increased central auditory gain. The reason what is explained is there may be extra neural firing, hypersensitivity of the nerve fibers, and extra auditory gain that is provided for auditory stimuli, and that could be the reason for hypersensitivity to such sounds. So that also needs to be managed for appropriate intervention. So this is also common, and in such patients also they require some management related to hyperacusis. Is how prevalent is hyperacusis? It's around 2%. So around 2% is the clinically proven, evidence-based research. The epidemiological result says that approximately 2% of them have hyperacusis. So 2% is generally, it is high. It is definitely a high percentage of individuals have hyperacusis, and even in children, it's almost 3.7%, and they have tinnitus as well. So considering this high prevalence, it is important that appropriate screening and appropriate assessment is done in individuals with hyperacusis. Okay, and I could not find any Indian-based study, so there is a research research idea related to this as well. So there has to be more studies with respect to prevalence of hyperacusis in an Indian context, and in adults and also in children, to know how much prevalence is there, so that can help us to better plan our strategies to early identify and rehabilitate those with hyperacusis. Because we get many patients with mild hyperacusis which they do not come to clinics, but they also require intervention because that can affect their emotional responses, and that needs to be addressed. And another important thing that we have to remember is the comorbidity of tinnitus and hyperacusis. Both of them coexist. Okay, so almost 25 to 30% of tinnitus patients have hyperacusis, and at least 2% of general population experience hyperacusis to various degree. And those with hyperacusis, almost 40 to 80% of them have tinnitus. So as clinicians, as audiologists, what we have to do is any patient who comes with a complaint of tinnitus. So what is usually done is we ask about the severity of the tinnitus, the type of tinnitus, duration of tinnitus, etc. And we ignore the hyperacusis component. Unless they complain about it, we don't ask about it. So, but as clinicians, it is always advisable that any patient who comes to our clinic with a complaint of tinnitus, always a question on hyperacusis should be asked, so that we get to know whether is there any component of hyperacusis as well, because that also requires equal attention for an appropriate management of tinnitus. And there are several medical conditions that can lead to hyperacusis. There are peripheral conditions and central condition. So any patient who comes to our clinic with a complaint of hyperacusis, it is always advisable that a medical checkup is advised. Medical checkup in terms of a physician who assesses the patient, and also an ENT who assesses the patient, and also a neurologist if possible. They assess the patient and they rule out all these medical conditions before they are admitted for maybe therapy for specifically for hyperacusis without any organic condition at the base. So it is always advisable that any patient goes for a detailed medical evaluation before we diagnose them as a pure hyperacusis functional case and not any organic pathology present. And we have talked about the theories. Dr. Ajit and Dr. Rajeshwari talked a lot about the theories. So why do we get hyperacusis? The reasons are hyperexcitation of the nerve fibers. There is an auditory stimuli, some amount of nerve fibers have to fire. If there are more number of nerve fibers firing, that makes the sound much more louder, and that may be leading to hyperacusis. There is an increased central auditory gain. The central auditory nervous system is giving more gain than usual. Okay, so because of that, the person is experiencing hyperacusis. So the strategies have to be devised, or the management strategies should work on reducing this hyperexcitation and the central auditory gain such that reduces hyperacusis. And the neurophysiological model given by Just Bob, that clearly explains hyperacusis as well. So tomorrow we learn in detail about the model and how it can be used for assessment and also for the management of hyperacusis. So moving on to the audiological assessment of the major portion, how I have a patient who comes to my clinic and he says I have difficulty tolerating sounds, given normal everyday sounds. So as audiologists, what all should be done? Okay, so the first important aspect is case history. So we have to take a detailed case history and we have to ask him about the description. Patient should describe hyperacusis and its presentation, which all condition he experiences it, what all is it affecting his daily life and all that. The functional impact or the quality of life impact of hyperacusis should be asked in much more detail. Is there any specific sounds that the person is having issues with? We have to ask questions to differentiate misophonia and phonophobia and all that, and take a detailed case history and collect lab test result, because to rule out or differentially diagnose, this is also equally important. So taking a detailed case history would be the first step in assessment of hyperacusis. And most of them will have all these functional limitations. They'll have sleeping issues, emotional issues, they'll have difficulty performing work tasks, social isolation and all this. So all these have to be asked, and we have to make a list of activities which are getting affected because of hyperacusis, because that would be our baseline for appropriate management, so that all these functional limitations should be overcome with the management option. So detailed case history on all these lines would help us to plan our management better. So audiological testing. Okay, so We use a standard audiological test, but especially in a client with hyperacusis, it will be difficult because they may experience pain, discomfort, or fear when we use a traditional audiological test. We should be careful about using the traditional audiological test. I'll explain about that. And in some patients, we also require balance testing. Okay, so vestibular evaluation or balance testing is important in individuals, some individuals with hyperacusis, because they also complain with vestibular issues, and there is a symptom called as Tullio's phenomena. So what is Tullio's phenomena? It is sound induced vestibular symptoms. I mean, the person hears a sound and he gets giddiness. Person hears some loud sound and the person gets giddiness or any vestibular symptom, and that is referred to as Tullio's phenomena, and that is more common in superior canal dehiscence, perilymphatic fistula, etc. All these conditions, and we use a term called as vestibular hyperacusis also, which means the vestibular system gets activated very easily, because vestibular system get activated only for very loud sounds above 110 120 dB, but even for soft sounds, if the vestibular moderate level of sound, if vestibular system is getting activated, when we call it as vestibular hyperacusis. So we should always ask them about balance issues as well, and if they complain of that, then it is always advisable that you do a detailed vestibular workup on them and identify if they have any of the vestibular related disorders, because that requires appropriate management in those lines as well. So I said audiological test. Which audiological test should be used? Hall and Haynes in 2001 suggested that these should be in your test battery. Okay, and PTA at octaves and mid octaves. You should do Pyoton audiometry at octaves, and I try doing also at mid octaves. Okay, and always try to use an ascending method. What I mean by ascending methods, always start from a lower intensity, start from a very low intensity and keep increasing the intensity, because suddenly if you give maybe around 60 dB, which is like normal for most of them, they may find it very annoying that maybe they're UCL. So don't give that. And what is also recommended is doing a loudness discomfort level, that is UCL, or a loudness discomfort level at pure tones. We do UCL for speech stimuli, but we can also do UCL for pure tones at octaves and mid octaves. High frequency audiometry beyond 8K, that is also recommended, because they may have hearing loss beyond 8K. So to understand that, it is always advisable to do a high frequency audiometry. Do SIS not at SRT plus 40. So find out the most comfortable level, and we should do SIS at that level. Emittance and reflexes, majority of the patient with hyperacusis, we may not be able to do it, because even if I have to do a tympanometry, the probe tone is 226 Hz, 85 dB SPL, that amounts to approximately 55 or 60 dB HL. So that may be intolerable to few patients. So I may not be able to do emittance. If I do emittance, if I want to do reflexes, always use ascending method, start from a very low intensity, maybe 55, 60, and then move ahead. So try avoiding it if possible, but if you have to do it, then do it in a careful way such that it doesn't make the person more uncomfortable. Do DPOE. So this is also recommended. Doing DPOE will tell us whether is there any cochlear involvement or is it cochlea is normal. So there's subtle cochlear abnormality not depicted in the traditional audiogram may be identified using DPOE. Do a vestibular assessment if a person complains of vestibular symptoms. So this is the test battery that has been recommended that can be used in an individual with hyperacusis. So this we do it, but is there any way we can classify hyperacusis in terms of the degree of hyperacusis? Can we say this is mild hyperacusis, moderate hyperacusis and all that? So there are scales which can be administered to know the degree of hyperacusis. So which are those? We'll be learning about them. Okay. So what is recommended by Oz and Moore is try starting from a low presentation level, and they suggested that start at 20 dB HL. Whenever a patient comes with hyperacusis symptoms, you always start at 20 dB HL. So Goldstein and Schulman in the year 96, way back in 96, so they gave a method by which we can classify hyperacusis. So what did they recommend? They said that you find out the loudness discomfort levels, that is the LDLs, at 250, 500, 1, 2, 3, 4, 6 and 8. At all these frequencies, you find out the loudness discomfort level. We'll have the pure tone thresholds, we'll have the loudness discomfort level, and we calculate dynamic range at each of the frequencies. All of you know how to calculate dynamic range. So we use LDL minus the pure tone threshold, that would be the dynamic range. We calculate dynamic range at each of the frequency. So how do we classify? So if a person has a dynamic range of 60 dB or more at all frequencies and LDL of 95 dB or more at all frequency, that is normal. A person has a 60 dB dynamic range and at least 95 dB as the LDL, then it is no hyperacusis. If a person has 50 to 55 dB dynamic range and 80 to 90 dB LDL, then it is mild. 40 to 45 dB of dynamic range, then it is moderate. 35 dB or less, then that clearly indicates that it's a severe hyperacusis. So this is one way of classifying the hyperacusis. And the second way of how we can classify hyperacusis is given by Marsha Johnson. It's called as Johnson hyperacusis dynamic range quotient. So how do we calculate that? It's similar to what was proposed in by Goldstein and Schulman. You have the air conduction threshold. You have the loudness discomfort level at 250, 500, 1, 2, 4, 6 and 8. That's at the 7th frequency. You calculate the dynamic range basically. You subtract LDL and the AC threshold and you get the dynamic range. So you sum all the dynamic ranges, that is for all the 7 frequency, divide it by 7. You basically take an average of the dynamic range and you will get a quotient, and that is referred to as the Johnson hyperacusis quotient. So once we get this quotient, that quotient has to be compared with this rating scale. So if it is it's between 75 to 90, we call it as mild hyperacusis. 50 to 74, it is moderate. Then you have severe and profound degree of hyperacusis. So these are two scales which can be used to categorize, the degree of hyperacusis. So as audiologists, we should administer either one of them to know a degree of hyperacusis. Why this is important is this would be my baseline for therapy. Okay, so after assessment, the next step is therapy. So I have a patient with severe hyperacusis. So I give therapy for the patient, I give treatment for the patient. So then I can administer this scale again to know the improvement in terms of the rating scale. After severe, it has to go to moderate, mild. So to judge the progress with the therapy, we can use this rating scale. So clinically, what is administered is either one of these tools can be administered to know the degree of hyperacusis. And what has to be done again along with this will tell the degree, that is in terms of the audiological way. But another important thing, as explained by Dr. Sriraj as well, we have for measuring the impact of tinnitus in the daily life, we have several tinnitus questionnaires. So similarly, even for hyperacusis, it is very important to administer questionnaires to know how much this hyperacusis is actually affecting their daily life. So that is very important because that will tell us what is the real effect of hyperacusis. LDLs are an indirect way, but to know the real life experience, it's always advisable to do a questionnaire and know which all areas the person has difficulty. So there are several questionnaires. First one is German questionnaire on hypersensitivity to sound, and the most commonly used is the modified Kalfa hyperacusis questionnaire. That was the first questionnaire that was developed, and you have a third questionnaire called as multiple activity scale for hyperacusis. So these are 3 standardized questionnaires, but these questionnaires also have some weaknesses. Okay, so hyperacusis questionnaire, it was validated on a general population, it was not validated on individuals with tinnitus and hyperacusis. Okay, and but recently people have adapted it into many languages. So many languages translation validation has been done with the Kalfa hyperacusis questionnaire. This MASH is not validated much, and German questionnaire is in German, but English version is yet to be validated. So considering this, we do not have any very standardized and validated questionnaire. Okay, so considering this, especially from an Indian context, what was found is we did not have any questionnaire specifically for hyperacusis. So to overcome that, we developed a questionnaire which published recently called, we developed a questionnaire called as Hyperacusis Handicap questionnaire. This was an outcome of an AIISH research project. Okay, so we tried to develop a hyperacusis handicap questionnaire similar to the THI, that is a tinnitus handicap inventory. Similar to that, we have 25 questions on functional, social and emotional aspects. So we had tried to validate those with tinnitus associated with hyperacusis. So in that population, we have validated it. So there is a lot of scope for clinician and also for student researchers to translate and validate in different languages and come up with something which is more relevant and more validated questionnaire, especially for individuals with hyperacusis in different languages in India and also abroad. Okay, on similar lines, there is a research in progress where we are doing we are validating or developing a hyperacusis impact questionnaire. This is in collaboration with Dr. Hashiraz, who is one of the speakers for tomorrow, who would be talking on CBT. So we are developing a hyperacusis impact questionnaire and validating it in different languages, and across the globe. It's happening across 8 countries and also in different languages in India. So we are coordinating it. Hopefully in next year we should be coming up with a validated questionnaire that can be used for assessment of a patient with hyperacusis. So again, why this is important? These questionnaires are important for again knowing the baseline, to know the improvement with progress. A questionnaire is very much important. So a client comes to me with hyperacusis, I should take a detailed case history, do the audiological test, administer some rating scale to know the degree, and also administer a patient questionnaire to know how much it is affecting the person's daily life. And Jastrabov in 1990 gave another classification of this, where tinnitus associated with hyperacusis, they gave different categories called as category 0, 1, 2, 3, 4, and what should be the possible treatment. I think it will be talked upon in detail tomorrow. So if it is only tinnitus and low impact on life, it is called as category 0. High impact on life with tinnitus, it is 1. But with respect to hyperacusis, tinnitus is present, and along with hyperacusis is present, but without any hearing loss and high impact of life, that is called as category 3. And tinnitus is present, and it is prolonged sound-induced exacerbation, which means the sound-induced problem continues for more than 1 day, then it's more affected. So person has to be treated more for hyperacusis. So these are category 3 and 4. So whenever a patient comes with tinnitus plus hyperacusis, we can find out which category they fall on, and we can plan an appropriate treatment strategy for them. And another important thing, as I said, is a team approach. There has to be a team approach where we send the patient to a neurologist, psychiatry, occupational therapy, psychology, otolaryngologist, physician to know the detail about, rule out and differentially diagnose, and then diagnose a patient with hyperacusis. So to summarize what the assessment part of it, though this was given in a recent article by Hall in 2019. So this is the way how we should approach or how we should assess a patient with hyperacusis. Any patient with hyperacusis or decreased sound tolerance comes to me, we should take a detailed case history, audiological information, if there is any medical information, details on which all problems he has, impact on daily life and quality life. So use this as a baseline in your clinic on assessing any patient with hyperacusis. Audiological assessment, do an otoscopy, tympanometry, DPOEs, pure tone audiometry till 16 kilohertz, word recognition, loudness, discomfort level. So these are must. Along with that, try to do a rating scale to know the degree of hyperacusis, and also a questionnaire to know the impact on the daily life. So based on this, an appropriate referral should be given to differentially diagnose. If it is misophonia, then psychological referral is a must, and along with that, cognitive behavioral therapy is needed. Hyperacusis, then we have an audiological management in terms of different options such as sound therapy, TRT, counseling, but nowadays even CBT can be done by audiologists who are working with individuals with hyperacusis. So this is an overview of how we should approach if I have a patient with hyperacusis. So I have a case report of a hyperacusis patient who was diagnosed at AIISH, Mysore. So this is a patient who had come with a complaint of irritation to loud sound, moderate sound, and he also had giddiness reported in both ears since 1 to 3 months. Okay, and here if you see, because of the COVID situation, we are not taking in-depth, in-depth review and all that. We have asked for him for a follow-up. So in this, what you have to understand, or what you have to relate it to what we have learned till now is, in this patient there is both hyperacusis symptom and also vestibular symptom. So you have to take in-depth interview of the patient with respect to the hyperacusis symptoms, how is it affecting the daily life, and giddiness, and that has to be evaluated in the patient as well. So this was an audiogram that we got in the patient, and if you can see, the uncomfortable or the loudness discomfort levels on these patients are at around 60 dB, so that is very low. And if you administer Goldstein and Schulman's criteria, this comes under moderate hyperacusis. Johnson hyperacusis quotient. This comes under severe hyperacusis. So moderate to severe hyperacusis, this is the audiogram that we got from the patient, and the Kalfa questionnaire, the normative is around 22. Okay, around 20 to 22 is the normative, but he got a score of 32, which means that it is really affecting the person's daily life as well. So what was recommended for this client is to go for a detailed medical evaluation as well. So to get a ENT and a neurologist consultation and also a psychological evaluation to be done. And since the person had giddiness, to rule out superior canal dehiscence, etc., we have the CT scan is also essential, and we have also recommended for a vestibular assessment for the client who would be coming for a follow-up, where we would be doing a vestibular assessment and checking for that. But here what was missing is we did not do high frequency audiometry. That is because of the present COVID situation. But if a person, same patient comes to you, what you have to do is take a detailed patient case history, do DPOE, and also do high frequency audiometry on the patient, and administer the questionnaires and use that as a baseline for diagnosing, and using and with appropriate referrals, we would be differentially diagnosing them, and then we would be taking them for therapy, and we would be using appropriate strategy for managing that patient. So what are the different management options available? You have informational counseling to make them understand why they are getting hyperacusis, what should be done, and all that. We will be learning about in detail about CBT, TRT, sound therapy, desensitization therapy, and hyperacusis activity treatment. So these are some of the options available for management of hyperacusis. So this is my last slide. So there are a lot of research opportunities for youngsters who are students and also who are working in clinics. Okay, so to try doing case studies or compilation of studies with respect to hyperacusis. There's a dire need to do a prevalence of hyperacusis in different parts of the world and also in India and abroad, and especially in children and adults, to know how prevalent is hyperacusis. Classification of hyperacusis is still I told about 2 studies, but there is a much more need where we have to come up with more appropriate ways of classification of hyperacusis if possible. And as I said before, there is a need for development of validated questionnaire for hyperacusis, and we should understand the relationship between tinnitus, hyperacusis, and misophonia. So there is a lot of role of audiologists now in management of hyperacusis and misophonia too. The research usually focus mainly on tinnitus now, but the research nowadays have to focus more on hyperacusis and misophonia too, to come up and understand the relationship between the 3. And we have a lecture tomorrow by Dr. Vinay, who will be talking about ICF model. So we are working on using ICF for tinnitus, but ICF model can easily be applied even on hyperacusis to know which all aspects are affected in individuals with hyperacusis. So we'll be learning more about that as well. So there are many more research opportunities, especially if you think in how we can identify and manage an individual with hyperacusis. So this lecture was an attempt to give you a brief overview about what all assessment tools are available, or if a patient comes to our clinic with a complaint of hyperacusis, how we can approach him to get a detailed evaluation done, which would be a baseline for me to plan an appropriate management strategy to improve or to help individuals with hyperacusis. So today is the International Day of Persons with Disability, and hyperacusis is definitely a disorder which can really affect the life of a person. So as audiologists, we should try our best to do the best so that we can help individuals with hyperacusis. So for any queries, you can put it in the chat box, or if you have further queries later on as well, so you can always contact me or mail also, and if we are open for any queries and also for any collaborative work if needed. So we welcome all that. So now any questions, you can post it, and the Google form link would be posted now, and you can answer it. Thank you for the opportunity provided to present on assessment of hyperacusis in this prestigious platform. Thank you.
Thank you, Prashanth, for the informative talk.